Okay, we're gonna get going, and so I want to briefly introduce Steve Galley from Stanford, who has been a regular faculty member at this course, and he's going to tell us all about allergic diseases. Thanks, Steve.
Thank you. Is my volume okay for everybody? So I'd like to begin with a story, and this is what my son used to call a true story. There was a child in our neighborhood who had a severe peanut allergy. And he was a very smart kid, and he was taught to read the ingredients on foods before he ate them and so forth. And he was at a friend's house, and he was offered ice cream. He reviewed the ingredients and didn't see peanuts listed. As soon as he took a bite of the ice cream, he knew there were peanuts in it because of the sudden local reaction, sudden within minutes, the local reaction in his mouth. And he told his host that he needed to go to the emergency room. And they did bring him to the emergency room, but there was some delay between the onset of the disorder, which of course is anaphylaxis, and the administration of epinephrine, and he died. And this is quite uncommon, actually. Most people with anaphylaxis will survive it, particularly if they're treated quickly with epinephrine after it occurs. But it identifies anaphylaxis as clearly the most grotesque imbalance between the cost and benefit of an immune response. You know, why do we have an immune response that would allow us to eat a peanut and die? And this topic is actually related to those you've already had, but different in that we're now going into diseases that are related to our responses to the external environment. And so what I'm going to do in an attempt to get to the end of my presentation is to focus on those aspects of the slides that have to do with what is special about allergic diseases and not go as much into the T-cell biology and B-cell biology. And you certainly can interrupt with questions. I would ask you to be prudent about that, because I have a feeling when the whole picture is painted, there'll be questions that will seem to you to be quite important, and I want you to have time to ask those at the end. So what I'm going to do is briefly mention prevalence, briefly discuss some of the components of allergic responses, go into some detail about the tissue manifestations seen in allergic disorders, talk specifically about asthma, look at the spectrum of allergic disorders, particularly with reference to the pathogenic role of IgE, briefly discuss some of the host environment interactions that may contribute to these disorders, talk about approaches for the management, treatment, and ultimately the cure, and then specifically discuss allergen-specific immunotherapy. So what are allergic diseases and what is the atopic march? So the allergic diseases we deal with most clinically are atopic dermatitis, also known as eczema, hay fever, here are the other names, and asthma. Food allergy is another example. And this is not the atopic march. This is the increased prevalence of allergic disorders in the 20th century. So this was a case report in 1819 of hay fever. So it was reported by Bostock in 1819. And now it's estimated worldwide, roughly 1 in 5 people have some sort of an allergic disorder. So that's not the atopic march. Is this due to genetic change? No. Much too fast for that. So this is clearly some sort of a problem in our relationship to the environment. What is the atopic march? Well, atopic dermatitis, if you're going to get it, about 50% of those with it will develop it by 6 months, and 90% that get it will get it by a year. And of these, 75% will develop hay fever. That's the first step in the march. So from atopic dermatitis to hay fever. And then 50% of those with hay fever will develop asthma, and that's the last step in the atopic march. So first atopic dermatitis, then hay fever, and then asthma. Some people have just this, some people have just hay fever, some people have only atopic dermatitis, but in many individuals it goes all the way through, suggesting that problems that manifest first in one anatomic compartment, the skin, can progress to others, the airways. So in the course of the latter part of the 20th century, using reasonably careful ways to define what asthma is, because it's really a combination of different disorders with a similar phenotype, the prevalence has been increasing in a startling way in many countries. And particularly Australia, New Zealand, United Kingdom, greater than 20%, Germany, Sweden, less than 10%, and so forth. So it's getting worse, and it's been referred to as an epidemic of asthma. What is the immunogens that produce an IgE response are referred to as allergens. So it's a circular definition. If it induces an IgE response, it's an allergen. I can't give you, from a structural point of view, the key criteria for allergens. There's no way to predict allergenicity from structure. But certain things are known about them. They tend to be soluble. They tend to be in this size range if they're particulate. They're stable in the environment. They can be compact. An example of that would be house dust mite pellets or feces. They persist in lymphatic organs. And all of these in aggregate prime these allergens to be able to get through secretions, mucus, membranes, and so forth. Some of the allergens, although not all of them, actually can get through epithelia in part because they have intrinsic protease activity. And DIRP1, which is one of the main allergens from house dust mite, is one of those. It has cysteine proteinase activity, which in vitro permits it to get through epithelial monolayers. So some, but not all, allergens have protease activity. And of course, what is the thought about the benefit of this type of an immune response, an IgE-associated immune response? Anybody? Parasites. So parasites are allergens. They induce an IgE response, and it's thought that in that context there may be some benefit to the IgE response. And some of the things we do when we have allergies, cough, sneeze, have diarrhea, may also help to expel parasites if we're infected with parasites. But let me tell you, it's been very difficult to prove that IgE actually has a beneficial role in parasitic diseases. There's some reasonably good evidence in mice, and there's some epidemiological evidence in humans, but it's not an easy sell. So what I'd like to concentrate here is not this. You've already learned about class switch recombination to IgE production, and it produces from the B cell IgE, and IgE is a bit of a one-note trumpet. Does everybody know what that means? It's an old-fashioned expression. It's a trumpet that can only play one note. And what's the note IgE plays? It doesn't fix complement. It doesn't get very well through the placenta. But it sticks very well to effector cells. And the two main effector cells shown here are the mast cell. Mast cells were named by Ehrlich as part of his thesis for the University of Leipzig. He called them mast zellen, or well-fed cells, because he thought these granules packed into the cytoplasm made the cell look stuffed, so mast cellin. They're distributed in virtually all vascularized tissues, and they're particularly prominent in surfaces exposed to the external environment, like the skin, the airways, the gut, the gastrointestinal tract, and the genitourinary tract. They can proliferate and expand their populations, contract their populations, depending on the cytokines present. And they're particularly prominent in parasitic disorders where they might expand many-fold in number. And different mast cells in different tissues have different propensity to produce different mediators. So some make heparin, some don't. Some make tryptase, some make chymase, some make both, and so forth and so on. So not all mast cells are the same. But they live normally in the tissues. They are delivered there as not yet fully mature progenitors, and then they achieve maturation in the tissues. And they're ready to go if they see antigen. If it's recognized, they don't intrinsically recognize antigen. They can only do so if they have an appropriate antibody, IgE, on the surface attached to a high-affinity IgE receptor, the Fc epsilon R1, which consists of an antibody-binding alpha chain, a 4-time membrane-spanning beta chain that acts as a signal amplifier, and 2 gamma chains that are the signaling components into the cytoplasm. So if the cell has on its surface IgE recognizing a particular epitope on a particular allergen, and 2 of them at least recognize that, so it has to be a bivalent antigen or a multivalent antigen, the receptors are brought in proximity, and this aggregation of the receptors is the signaling event that then causes the cell to exteriorize its granules, producing a release of vasoactive amines and granule constituents like proteases, heparin, and so forth. And the cell is also activated to synthesize new products, including products of arachidonic acid metabolism, leukotrienes, and prostaglandins. And it will secrete many chemokines and cytokines as well. So that's a key event in the initiation of an IgE-dependent reaction. Now, in the circulation, as the least prevalent of the granulocytes, usually less than 1% in our circulation, we have basophils, and these in many ways mimic the activities of mast cells. They have the high-affinity IgE receptor. They can be activated by IgE and antigen. They can produce a partially overlapping spectrum of mediators. So if the antigen is injected intravenously, for example, penicillin in a penicillin allergic individual, the basophil may be the first to react. If the antigen is injected into the skin, for example, somebody who's allergic to bee or wasps, the animal injects its venom, activates the mast cells first, and then as the venom goes systemic, they'll activate the basophils. So this is the event. So how many antigens can these cells detect? How many antigens can a T cell detect? One, right? The cognate T cell is recognizing one. These are much smarter. I told Mark Davis that if mast cells were easy, we would call them T cells. They're very smart because they can bind IgE of various specificity. So the number of receptors on the surface of the mast cell is in the range of 100,000 to 500,000. The number of aggregated receptors necessary to trigger the cell is in the range of 10 to 100. So let's call it 100. Let's say it's got 100,000 receptors and 100 aggregates can trigger the cell. So that means it can be, in theory, sensitized to 1,000 different antigens, each one with 100 IgE that can recognize that antigen. So these acquire passively antigenic specificity from the IgE. So Shiv went into this, and IgE is produced by deletional class switch recombination that generates these excised circles, and this is sort of a marker that that event has occurred. And he told you that that event occurs where, anatomically? Spleen, lymph nodes, skin, lymph nodes. But it can also, based on the work of Hannah Gould in England, who has detected these excised circles in the airway lymphoid tissue of patients with asthma and also in the gut lymphoid-associated tissue in patients with food allergy, she can detect these circles, and sometimes in patients with very low levels of circulating IgE. And she's proposed the very interesting hypothesis that some IgE production, including class switch recombination to produce that IgE, can occur locally in the tissues affected by disease. Why might this be important clinically? Well, in some patients with asthma, maybe 90%, it's quite clear that they have an allergen that induces the airway response. In others, there's no allergen that can be identified. But sometimes the pathology looks the same, and I'll talk about that later. So her concept is that there may be some patients with asthma that do have an IgE component, but the IgE being produced locally is in very low concentration in the serum and maybe to an antigen that is not yet identified. But the important take-home message, at least in the case of IgE class switch recombination, that can occur peripherally in the affected organs. And this is simply to remind me to tell you that when co-stimulatory molecules are engaged between the B cell and T cell, this can result in changes that can amplify the response. So the story of allergic disease is in many respects the story of amplification mechanisms gone awry. And I'll be coming back to that theme periodically in the talk. So in this case, CD8, CD80, or CD86 engagement can upregulate CD40 ligand, which can cause a co-stimulatory signal here that drives the cell toward IgE production. And by the way, mast cells and basophils can also express CD40 ligand and can substitute, at least experimentally, for T cells in driving that reaction. And the production of IgE, if that's the step you're interested in thinking about how do we deal with allergic diseases, is under complex positive and negative regulation. You've heard about IL-4, which works through STAT6, CD40, which works through NF-kappa B, CTLA-4 can interfere with both of these, and it can be modified by other cytokines, such as IL-21 and interferon gamma, that can have negative regulatory effects. And we'll come back to interferon gamma later in the presentation. So I want now, in a series of slides, to introduce the concept of the complexity and redundancy in mechanisms of allergic disease. I'm not going to describe everything that's on the slide. Don't worry about that. And with the help of the reviewers, I didn't give you a reference here because this is not yet out, but there's going to be a special issue of Nature Medicine on asthma and allergic diseases, and a modification of this will be in that article there that we did for them. So what we're showing here is IgE, in this case in blue. And this is IgE. We don't know its antigen specificity. It's just your basic antigen non-specific IgE. Here's antigen-specific IgE, and I'm going to tell you how it happens, how we get that. So you've got, in this case, an epithelial barrier, the airway lumen. You've got CD23, which is a C-type lectin that exists as a trimer when it's membrane-associated, and it can transport IgE across the membrane. That's going on sort of at a steady state all the time. And you've got dendritic cells, macrophages, and mast cells, each of which can have a version of the high-affinity IgE receptor. So the mast cell has got, as I told you, the alpha, beta, gamma, gamma form. The dendritic cell has got an alpha, gamma, gamma form. It lacks the signal-amplifying beta chain, and so does the macrophage. It has the alpha, gamma, gamma form. So these are other cells that can bind IgE by high affinity. So what happens? You've got an immunogen, in this case an allergen, because it's going to be producing an IgE response, and it's getting through the epithelium. Let's say it's one of these that has a protease activity. It gets it through, or maybe the membrane has some problem in barrier function, and the antigen gets through. So the antigen gets through, and then it's picked up by a dendritic cell, and the dendritic cell does its thing with the T cell, and the T cell interacts with the B cell and induces class switch recombination, and we now have IgE against epitope A of this antigen. There may be multiple epitopes on the same antigen, so IgE can be produced at different tertiary structures on the antigen, and this one is produced against epitope A. So that's the basic. So now you've got some IgE against that antigen. So what are the amplification mechanisms? And there are a lot, and there are only some of them illustrated on this slide. So once you have antigen-specific IgE that recognizes epitope A, well, now that can be transported by CD23 through the epithelium. And what happens then? Well, if that gets to a mast cell, that mast cell, by binding two IgE antibodies to the same epitopes on that allergen, can be activated. And among the things it makes are IL-4 and IL-13. So mast cells can do that too. And the IL-4 and IL-13 can drive this process to produce more IgE. A second mechanism is that the mast cell, in its degranulation event, is also producing factors like histamine, TNF, and PGD2 that can influence the migration of dendritic cells or the maturation of dendritic cells. So mast cells promote this transit of dendritic cells to the scenario, the Th2 cell, where they can interact with them to drive further IgE production. Then a fourth mechanism has been called facilitated antigen presentation. So now you've got a B cell, and this B cell may not be specific for this particular epitope, but this B cell has CD23 on its surface, right? And IL-4 and IL-13, which could come from this source or many other sources, can upregulate CD23 in the B cell. It then captures IgE antigenically nonspecifically. It's just looking for IgE, and it grabs it. It's got this epitope, and then that B cell interacts with a cognate T cell, but may present a different epitope that's present in the same antigen. So the basic concept is the antigen may have 5 or 6 different epitopes. You've already got IgE to one of them, and now through this mechanism, you make IgE to a second epitope of the same antigen. Or B cells could pick up other antigens that happen to be around with other IgE that may be around and deliver that, and you get an amplified IgE response. This is called epitope spreading. And the fifth is the basic mechanism that if you have either macrophages or dendritic cells that have bound, again, complex antigens with multiple epitopes to their surface, through the alpha-gamma-gamma form of the receptor, they can also drive this process. So people with allergic diseases, for example, children with food allergy, may start out with allergies to one food, and then in the course of their atopic march, their personal journey through allergic disease, they may develop allergies to multiple foods to the point where the kids carry their own food to meals because they're so uncertain what they might eat might have one of their allergens, and they eat carrots and celery and things like that. Okay, so now I'm going to assume that we've got IgE recognizing this antigen. So we have a person who's called, what do we call this person? Sensitized. The person is sensitized. They have IgE to this antigen, and now they breathe that into their airway. So what happens? Let's say their airway, this is very early in their disease, and their airway is basically normal, except the mast cells in the airway have got IgE recognizing that antigen. So the mast cells aren't making things at that time, basically. That's not wholly true, but basically they're quiescent. They're waiting for their antigen. They're looking for their antigen. So here comes the antigen. The antigen comes through. Maybe there was a viral disease, and the barrier function of the epithelium was broached. But in any event, the allergen gets in, or it's brought in by dendritic cells. It reaches the IgE, not this IgE, because we don't know what that's specific for. That's the antigen-non-specific IgE. It goes to the antigen-specific IgE. It aggregates the receptors. They send a signal that activate the cell, and all of these mediators come out. All histamine, prostaglandin D2, LTC4, TNF kinase, PAF, VEGF-A, IL-8, CCL2, and so forth. And what do these do? These are not working on other innate or immune cells because they're not present in the normal airway. So these are acting directly on target cells like nerve cells, goblet cells that produce mucus, smooth muscle cells that produce bronchoconstriction, and on the blood vessel causing vasodilatation. These are the mediators implicated in that. And also, these are chemotactic factors, CCL2, IL-8. TNF upregulates adhesion molecules on endothelial cells. So processes are set to work in the blood vessels that don't work within minutes, but work over a period of hours to recruit leukocytes to promote their emigration and to activate them at the site. So the immediate hypersensitivity reaction, I had a guest who came into our house, prominent scientist at Stanford, and she had not taken off her coat. She said, "Do you happen to have a cat?" Now, she knew we had a cat because her airways were closing down 2 minutes after walking into our lobby. No, it's not a lobby. We're in the country now. It's a foyer. She walked into the foyer, and her airways were closing down. I said, "Yes, we have two." She said, "Thank you, I better leave." And so she pulled something out of her purse that she was going to take, and then she left. And we always ask now, do you have cat allergies? I'll get back to cat allergies in a minute. So this happens very, very fast. It doesn't depend on recruiting leukocytes. It depends on the mediators that are released by the cell and act directly on the target cell. So that's the immediate phase response. And when this is systemic, then you have anaphylaxis. The airways, the gut, the skin, that's anaphylaxis. But this is slower, and we can't forget about that because there's going to be a consequence. And the consequence is what's called the late phase response. And this develops 2 to 6 hours after the early phase or immediate reactions to challenge with specific antigen. I know this person, I won't tell you who it is. And this is the early phase response, and that's the late phase response. So this happens 2 to 6 hours after injection of antigen, and this happens within minutes. So how does he have both of them at the same time? Exactly. He comes every year. He comes every year. They were injected at the same time. He did this for the textbook. And so there's the early phase reaction, the wheal and flare. That can go away, and then the late phase. And so how does this turn into this? All the effects of those early release mediators that have long-term consequences with respect to leukocyte recruitment and so forth. And you can do this in the airway too. So you get volunteers who are allergic to something, antigen, and you blow it into their airways while you measure the forced expiratory volume 1, which is how much air you can expel in 1 second from fully inflated lungs. And then you measure it, and you measure it over time. So here's the poor volunteer, maybe a medical student. They've taken the antigen. They go down, 95% reduction in their airway flow, and then it recovers rapidly, and then they feel good at this point, and then, uh-oh. So what's happening here? This is the contribution of the leukocytes that are recruited to the response, most of them innate. But there may also be some T cells in there too, Th2 cells, and possibly Th17. So there's the immediate, there's the late phase. So this is all due to cells resident in the tissue, including the mast cell, which is the effector cell, and this is due to cells recruited to the tissues. Now, only some sensitized subjects develop late phase reactions. We don't know why, but it's presumably got something to do with how they manage the late phase of their inflammatory response induced in the immediate response. And rare patients will develop this without developing that. We don't know why that is either. Okay, so this is the late phase reaction. What's it look like if you're interested in the cells and mediators? Well, there are new players present. Basophils are now present. There are more monocytes and macrophages. There are Th2 cells. There are eosinophils. There are neutrophils, particularly in individuals who may have Th17 component to their allergy. And I'll get a little bit into that later. And the pathophysiologic manifestations reoccur. So now bronchoconstriction has come back. There's increased vascular permeability again, and so forth. And that reflects the many different things all of these could do to the resident cells. But at this point, the resident tissue is still basically normal. So nothing has happened that has changed the number of goblet cells or the amount of smooth muscle or the amount of extracellular matrix material underneath the epithelial membrane. So it's still a normal tissue, except it's got an inflammatory response going on. So for the definition of asthma, asthma affects roughly 7 to 8% of the population in the United States. As I said, the great majority have a defined allergen, some don't, and there are different types of asthma. And there's a lot of interest in subphenotyping asthma in the hope that that might help you find particular agents that will work in that group of asthmatics and perhaps not in other groups of asthmatics. I'm not going to go into that today, but it's a very interesting area. So whether you have a defined allergen or not, how do you define asthma? You do it based on basically 4 features. So one is reversible airway narrowing. You experience the antigen, like my friend who came to our house, the airways narrow, you go away where there's no more antigen and they relax, so it's reversible. That's one characteristic. Immunologically nonspecific airway hyperresponsiveness. I don't happen to have asthma. If you wanted to cause my airways to contract, you might need this much histamine, but if there was somebody who had asthma for whatever reason, you might need that much histamine, maybe 1/10, 100th amount. So, and that's not related to the immune response, that's just the sensitivity of the airway to this immunologically nonspecific trigger. I should correct what I just said. The immune response may be responsible for changing the responsiveness of the airway, but the agonist used, histamine, methacholine, isn't necessarily generated by the immune response. You can just blow it in directly from sigma. Chronic inflammation of the airway. It's now known that in asthmatics, even under treatment, the airway has a chronic level of inflammation. So these innate cells and immune cells are present. And airway remodeling, which is a newly appreciated important aspect of asthma, where the tissue actually changes. So you're changing the rules of engagement by changing the structure of the underlying organ. So this is a figure we published a few years back. Here's a normal airway. Here's the epithelium. Here's the smooth muscle blown up. Here's the smooth muscle. Here's the submucosa, the epithelium. There are a few cells that look a little foamy in the H&E, and with a special stain that makes mucus red, you see they're making mucus. So those are the goblet cells. Here's a patient with asthma. The entire lumen of this airway is full of mucus. You can see a huge number of goblet cells making mucus. You can see increased mass of smooth muscle. You can see extensive inflammation in the submucosa, including eosinophils for those in the front row. And you can see there's a lot of mucus production shown here as well. And mast cells change in their distribution. They suddenly are appearing in the epithelium, which isn't seen in the normal individual. They're present in the submucosa, and in some patients with asthma, there are increased numbers of mast cells in the smooth muscle. So you can look at this by any different mechanism. You could do ultrastructure, you could do assays for cytokines and chemokines. There's basically a lot going on in the remodeled tissue. It's structurally different than normal. This particular review is interested in TNF, and you can read all the different things TNF might be doing that could promote this tissue remodeling, but you could pick any of a number of other cytokines, chemokines, and mediators and produce a similar story. They have multiple overlapping effects, which can confound treatment. Attempting to treat people with severe asthma with anti-TNF has so far not proven very effective, probably because it's redundant in its effects in this setting. So let's go back to the kind of diagram I've shown you for the immediate response, the late phase response, and the now chronic inflammation and tissue remodeling. So go back to my friend with a cat allergy. She visits me and she's exposed to antigen. She visits somebody else and she's exposed to antigen. This is her life. She doesn't take her coat off before she asks whether there's a cat in the house. And she will be exposed again and again. Or people with house dust mite allergies, they're exposed again and again. And so they have repetitive induction of what? The immediate response and the late phase response, again and again and again. And so over time, their airways change. They've been exposed to these cycles of inflammation again and again. And they've got a number of players now in the submucosa and elsewhere, in addition to the mast cell. And look what's happened to the mast cell. So now epitope spreading has occurred. So this particular orange allergen, you know, the red IgE recognizes one epitope, the green recognizes another. Here's another fun thing about IgE and mast cells. It was thought that IgE sitting on the mast cell delivered no signal to the cell. It was just sensitizing it to recognize antigen. But we and others have shown that actually there is a kind of signal that occurs when that happens. And one of them is to stabilize expression of the receptor at the surface of the cell, so that if you have high levels of IgE, you have more IgE receptors on your mast cells. This is now very well established both in mice and in humans. A second effect of binding IgE to the receptor, particularly with certain types of IgE, is that the mast cell gets a stronger survival signal and may produce some chemokines and cytokines at low levels. This is not in the presence of the known antigen. This is just with the IgE sitting in the membrane. So this cell is not only primed in the sense that it has IgE against two different epitopes on its surface, but it may also have gotten this priming signal from the IgE by itself that maybe has improved its survival, helped to increase its numbers in the tissues, and makes it a better effector cell when it finally interacts with the antigen. And then you've got Th2 cells. Some of the people who develop late phase responses without an early phase response may be actually experiencing a kind of a T cell response to allergen that doesn't have much of an IgE response. And you've got all of these innate cells that have been recruited that are producing lots of interesting things that can affect many of the resident tissue populations. Smooth muscle mass increases. Mast cells now can appear in the smooth muscle, which puts them in proximity to the target organ, right? The target cell is the smooth muscle cell, and now it's living right next door. The number of goblet cells is increased. Epithelial injury can occur. One of the most common being viral infections will exacerbate asthma attacks in people who have asthma. There's a change in the underlying tissue, which is referred to as the epithelial mesenchymal trophic unit, where factors in the epithelium and in the underlying submucosa derived from epithelial cells, fibroblasts, myofibroblasts, interact to produce a pro-Th2 environment, including increased TSLP and other TSLP shown here, and other factors that can make this even worse. So this is another example of the amplification mechanism that can occur in allergic disease. And how do you treat this? I'll get back to that at the end. So that's, and one last point, the airway now is altered, right? There's more smooth muscle, there's more inflammation, there's a thickened submucosa because of the inflammation. So the airway is narrowed in such an individual at baseline. And flow through a tube is a fourth power function of the diameter. So since this airway already is narrowed, if then there's an acute exposure to antigen, the amount of compromise is even greater. So people with asthma are at great risk for a fatal outcome, for example, with food allergy. If they're unlucky enough to have both food allergy and asthma, they are at significantly greater risk to have a fatal outcome from food allergy because their airways are already compromised at their baseline. So the T cells that have been of most interest initially in the context of allergic disease are the classical Th1 and Th2. The list is growing much longer, and it's particularly important to consider Th17. Asthma had been thought of to be a disease characterized by eosinophil infiltration, and that's true, but as more and more populations of asthmatics have been defined clinically, particularly those with severe asthma, many patients with severe asthma have large numbers of neutrophils present as well, and it has been possible in their bronchoalveolar lavage fluid to identify IL-17, IL-17A, other products of Th17 cells. The Th17 cells have been identified by flow, and it's thought that in at least this population of severe asthmatics with neutrophils as well as eosinophils, the Th17 cells as well as Th2 cells may have an important pathogenic role. But so far there's been no specific targeting of them in that setting. So I started the discussion by saying that we circularly define allergies as those reactions to environmental antigens that are associated with IgE against the antigen, right? And I told you that these are the disorders, anaphylaxis, hay fever, asthma, and atopic dermatitis, that are associated with IgE production. And then the question is, if you have these diseases, and this is an interesting question because it is possible to target IgE now. So if you have these diseases and you target IgE, will that work in their treatment? So it turns out, paradoxically, that the disorders in which there is the strongest evidence for a pathogenic role for IgE in the ongoing disease process. Of course, T cells are always required to get IgE production, but in the ongoing disease process, you know, which of the disorders where IgE has the most prominent role? Well, anaphylaxis, certainly. You can challenge them with antigen. You have to do it how? Very carefully, with very small amounts. But you can challenge them and see what are they allergic to, and that's an immediate response. Remember, that's just what's in your tissues, not anything that's circulating. The IgE is fixed. That sounds exciting. Whose is that? I should pick up the pace, maybe. So the role of IgE here is very clear. And in mice, if you have mice with no IgE, you can't give them an immediate response by injecting antigen in the skin. It's entirely IgE dependent. Hay fever, nobody who takes care of these folks doesn't think it's an IgE dependent phenomenon. And asthma, occasionally. At the end, I'll talk about the anti-IgE, the humanized anti-IgE omalizumab. And in severe asthmatics, moderately severe asthmatics, some patients respond reasonably well to that drug. So there is a role. And in the past, some asthmatics were treated with immunosuppressive treatment, and that has been one of the arguments that there was a T cell component, among other arguments. And then finally, atopic dermatitis, where still now some of the patients with severe disease are treated with immunosuppressive agents. They have huge amounts of IgE, but most clinicians would say they're really not sure how much of the chronic pathology is IgE related. So again, once the allergic disease starts, there are all sorts of amplification mechanisms that by their nature result in the recruitment of redundant effector pathways into the disease. It's best to avoid allergen in the first place than to have to worry about treating it when it gets to that. Yes?
Fernando Martinez has talked about sputum samples from kids with asthma exacerbations.
Yeah.
And some had a lot of neutrophils, some had a
Right.
lot of eosinophils, and then there was quite a bit that they were acellular. How do you describe what's going on there from an immunology perspective?
Well, you can't give a complete explanation. There's a technical issue, like which level of the airway is involved and how likely is it that you can get induced sputum that will be reflective of the real players. Because the real players are in the tissues, they're not in the sputum. So the sputum is kind of overflow from the tissue. So I think what he's getting at is something I mentioned earlier, that it's now thought clinically you have subtypes of asthmatic patients that can be defined in part by different responses to drugs. You have those that respond to leukotriene antagonists and those that don't. You've got those that respond to anti-IgE and those that don't. And so how many diseases is asthma? It's clearly more than one. It's just defined by a phenotype, which is reversible airway narrowing, airway inflammation, nonspecific airway hyperresponsiveness, and remodeling. And some patients, there may be no immunological mechanism. So I think it's just an example that there are subphenotypes of asthma. So what's wrong with our relationship with the environment? And this has been referred to as the hygiene hypothesis. This is an old review, but it's still pretty reasonable. There are all sorts of things that are dirty, like you could call them dirty, like your siblings, daycare centers, farming environment, helminth infections, microbial exposure. And then there's the clean environment. I wouldn't go so far as to call it sterile, but the urban lifestyle, only child. And this tends to result in a Th1 biased immune response, and this tends to result in a Th2 biased response. And the key thing is, everybody agrees with this. There are a lot of epidemiologic studies that support this, but what's the mechanism? And there's been a lot of discussion of different mechanisms. This is one proposed by Sergio Romagnani. And it basically, the details are shown in the slide, and you can read his article. It's kind of a nice article. And it's basically that dendritic cells in an environment with lots of toll-like receptor ligands and repetitive stimulation with these toll-like receptor ligands are induced not only to produce IL-12 instead of IL-4 when those are absent, but the main ligand for Notch changes from predominantly jagged to predominantly delta, and this results in a more Th1 biased than Th2 biased response. And there may be something to this. So if you go into German farm sheds, which I highly recommend, and you look for, you muck around and you look for what bacteria are present, you can find at least two that can do this in mice, that can polarize toward a Th1 myeloid dendritic cell, and they do that both by increasing IL-12 production and increasing delta expression. And then you've got the Allergic study in Europe, which shows decreased atopic sensitization, meaning lower incidence of finding IgE to various antigens, lower prevalence of hay fever and asthma in kids raised in a traditional farming environment. So this has led to thoughts that maybe by changing diet, giving probiotics, exposing kids to more of these types of factors earlier in life, maybe this will help them avoid getting allergic diseases. What's the difference? It's about a 2 to 3-fold difference if you take genetically similar populations, either they're living in the farming environment or not in the same communities. The kids living in the farming environment have about a 50% reduced incidence of asthma. So I want to now spend a few minutes on what separates us from the environment, which is basically our epithelial barriers. And I'm going to focus particularly on the skin. So here's a cartoon of the skin, and it responds to all sorts of challenges, including microbial challenges, by producing various active defenses and also by eliciting help from the innate and adaptive immune response. But it also has mechanical barrier function, and that occurs at the stratum corneum, the surface of the skin. So if you do GWAS studies looking for susceptibility loci for asthma, atopic dermatitis, and other immune disorders, you see some interesting things. So here's the list of disorders. So no one thinks psoriasis is an allergic disorder, although people do think asthma and atopic dermatitis are. And here's chromosome 1. And here's 1q21, which is the epidermal differentiation cluster, and this is about a 1.6 megabase segment of DNA that contains at least 50 genes involved in keratinocyte differentiation, and they're clustered here in the epidermal differentiation cluster. And these GWAS studies have identified this as a site that increases risk for atopic dermatitis and also for psoriasis. So what's common about those disorders? They both involve the skin, but one's allergic and one is not. And so if you look at the other genes that have been associated through GWAS studies with increased risk for asthma, and I've got to tell you at the beginning, except for the one I'm going to discuss next, none of these have a very big effect. Or even in aggregate, they don't explain a lot of asthma. These are very small effects, albeit statistically significant ones. So there's Sphinx, which if mutated can result in Netherton syndrome, which is congenital erythroderma with very high levels of IgE and atopic dermatitis. Sphinx is a proteinase inhibitor, suggesting that the lack of this protease inhibitory function at the skin barrier may somehow result in these allergic manifestations of the disorder. But a number of other genes have been identified either in the epidermis or epithelium of the airway itself, CLCA1 in mucus producing cells, TNF, the beta chain, which is the signal amplifying chain of the high affinity IgE receptor, mutations there can be associated with increased risk. So these are cells that either live in the epithelial or live close by, and also some smooth muscle genes. So none of these have had an aha type of response. We now can understand better allergy and asthma. It makes sense that such mutations may contribute, but they do so to a relatively small extent. But this was the big hit. This is filigrin, which it's named after filament aggregation protein, filigrin. And what filigrin does is help to aggregate intermediate filaments in the keratinocytes to permit them to be cross-linked by transglutaminases. And this helps produce the physical barrier of the skin. And so you can actually see these filigrin granules in the keratinocytes. They're these dark structures. And this is how normal skin looks. And this is how skin looks if it has no filigrin granules. And this could be, this is a case of a particular kid with both ichthyosis vulgaris and atopic dermatitis. So loss of function mutations in filigrin are carried by about 10% of ethnically European individuals. And this can cause ichthyosis vulgaris. It's in a autosomal dominant inheritance with partial penetrance. So if you have one of the more prevalent loss of function mutations, you have a single copy, then you have about a 40% chance of having ichthyosis vulgaris. And if you have two loss of function, you have about a 70% chance. So it isn't determinative, but it's a very high risk of ichthyosis vulgaris with these mutations. And these individuals with a single loss of function mutation also have a high risk for atopic dermatitis, a really high risk. So if you have two loss of function mutations, your risk for atopic dermatitis is about 90%. If you have a single loss of function mutation, you can have up to a 7-fold increased risk of atopic dermatitis. So this was the big hit. This was the big barrier-associated protein, which, if mutated, results in a markedly increased incidence of allergic diseases. And it's thought to be because of a perturbation of the barrier function of the skin, presumably to antigens, although that hasn't been formally proven. But that's the mechanism that has been proposed. Now, remember the atopic march. So it starts out in the skin, and it goes next to the, mine is large, nose, and then it goes to the lower airway, asthma. That's the atopic march. Well, folks have looked for filigrin expression in the airway epithelium, and is it present? No. And why is that important? Well, that suggests that since these kids with loss of function mutations at filigrin go on in many cases to develop the atopic march, so they start with the skin problem, then they go on to the hay fever and they go on to asthma, that an allergic disease that starts because of a barrier problem in one organ, the skin, can result in a systemic immune disorder that involves multiple organs, even though it started somewhere else. And that's probably reflective of all the amplification mechanisms that I talked about earlier. So a little bit about picking your antigens, and how are we doing on time? Because I know I'm between you and lunch, and that's not a good place to be.
About 30 minutes.
Good, we're doing well. I mean, I think we're doing well. I don't know. So this is a highly magnified set of dust mite fecal particles. And DIR-P1 is the allergen I mentioned, which is a cysteine proteinase. And among its targets, by the way, are CD40 and CD23. So it actually can proteolytically degrade some of the components of the allergic response. And it contains small amounts of DIR-P1. It also contains endotoxin, bacterial and dust mite DNA, and chitin, which I'll get to in a minute. And if you have a skin test positivity for dust mite, which means you've got IgE in your skin, you inject the dust mite, you get a wheal and flare. So that's skin test sensitivity. If you have that, then your risk for getting asthma eventually is about 20-fold increased. It's very well established. So it's a very important allergen with respect to the development of asthma. Now, the cuticle of the dust mite consists, among other things, of chitin. So chitin is the second most common polymer in biology, second to, what is the most common polymer? You see them in Muir Woods, cellulose. So cellulose is the most common biopolymer. And this is an N-acetylglucosamine polymer with a beta-1,4 linkage. And so that's chitin, and it can be found in the hard exoskeleton of arthropods like dust mites. It can be found in the skeleton of fungi, shellfish, and so forth. And there's something interesting about chitin, and that is it can induce innate cells like alveolar macrophages or tissue macrophages to release leukotriene B4 and chemokines, and that in turn can recruit additional innate cells such as basophils and eosinophils or immune cells, Th2 cells, and those are turned on for production of IL-4 and IL-13. So this is a kind of Th2 adjuvant, if you want to think of it in that way. So the dust mite has not only the DIR-P1, which induces an IgE response and is recognized on next exposure to dust mites by IgE on the surface of mast cells, but also it's got this adjuvant-like property of producing chitin, and chitin can rev up innate mechanisms that contribute to a Th2 response. So I want now in the final part of the presentation to go into what can we do about all this. And so one simple thing is simply avoid the allergen, and this is key for food allergies, of course, but it's also important in some of the more common types of allergic responses like airway responses to dust mites. So here we're looking at 20% fall in forced expiratory volume 1. So how much histamine does it take to do that? And so this is the good direction. You want to be moving in the direction where it takes more and more histamine to cause an airway constriction. And this is the months in a sanatorium at Davos. So Davos, the town, is at about 1,200 meters. And it turns out house dust mites don't like high altitude. And by 1,600 meters, roughly, there aren't any more. And at 1,200 meters, there are very few. So they like to live in relatively, there are a lot of them in this carpet, for any of you who may be wondering. They basically eat desquamated skin, and so wherever we are, if we're in a low enough altitude and there's sufficient humidity, you'll find house dust mites. So they took these people and they basically knew that at baseline they had a very high sensitivity to histamine to produce this bronchoconstriction. And then if they went up to Davos, which is a very pretty place, and stayed for a while, they would lose that because they weren't any longer exposed to house dust mites. So reduce exposure to the allergen. And Tom Platts Mills did the same thing at the same virtually sea level altitude of London. by just putting them in a room where there were no house dust mites. Now, if you're sensitized, are you allergic? Not always. You can be sensitized and not demonstrate clinical allergy. So you've got the IgE, but you don't have the disorder. And if you are sensitized, you need to be exposed to the allergen to show the disease. So this was a very nice study published some years ago in the New England Journal of Medicine. And it focused on inner city kids where one of the major allergens is cockroach. Now, they spend a lot of time indoors because it's not safe to go outside, and they tend to eat in their room, and the cockroaches come at night, and they get a lot of exposure to cockroaches. And so we have here 4 groups. So groups 1 and 2 are not sensitized, so you can't find IgE for cockroach in those kids. Groups 3 and 4 are sensitized, so those have IgE to cockroach. Then groups 1 and 3 were not exposed to high levels of cockroach. So groups 2 and 4 were exposed to high levels of cockroach. So what this shows is what you would expect, but it hadn't been so nicely demonstrated up until this time, that if you're sensitized, you need to be exposed to high levels of the antigen to produce the disease. And so here's hospitalizations, here's wheezing. This also was significant. Unscheduled medical visits, change in caregivers' plans, and so forth. So you need both to be sensitized and you need to be exposed. And in this particular population, their asthma was cockroach related. So they had, many of them were also sensitive to dust mites, many were sensitive to cat allergens, but that didn't seem to be associated with the disease. It was the cockroach in this case, which I guess could be considered promising if you're thinking of antigen-specific immunotherapy. They have a very specific type of antigen. This is a cat here, and FeLD1 is a 18 kD protein of unknown function, secretoglobulin, but it's very sticky. And so they lick their hair, and it gets on the hair, and the hairs float around and stay in the environment. And also, this cat dander, or these hair particles, contain not only FeLD1, but cat albumin, cat DNA, endotoxin, and so forth and so on. And the exposure is huge compared to house dust mite, orders of magnitude greater exposure in a house with a cat and house dust mites to the cat allergen than the house dust mite. And this produced some very interesting findings. Remember, New Zealand is one of the places with very high incidence of asthma, high prevalence, and about 20% of the population wheezes, and mostly it's a mite-related asthma. And this study involved 112 children with wheezing, 112 controls taken out of 1,500 kids in the population. So there were 55 with asthma living in a home with a cat, and of these, 34 were sensitized to mite but not cat. So why were they living in a home with an allergen and not sensitized to the allergen? Any ideas? So I told you there's huge amounts of allergen. They're living with a cat. They were desensitized. Well, we could say tolerized, but we'll get back to that. So there's something about certain types of exposure that even though they're allergens, don't result in disease. They actually result in a kind of protection from disease, which is very good news. And so cat ownership was associated with decreased sensitization to cat, meaning they couldn't find an IgE response to the cat when they tested the kid, but had no effect on mite IgE. So the cat, there wasn't a transfer of protection from the cat to the mite, unfortunately. So this is a study, again, done by Tom Platts-Mills, very nice study. So he looked at increased exposure to cat allergens. So this is the amount of cat allergen you're exposed to on this scale. And this is the number of kids that are sensitized to cat allergens, so they get a wheel and flare response to the antigen. And these are the number of kids with a high IgG response to cat, to FeLD1. So you can see that sensitization occurs, peaks at this level of exposure, but then goes down in parallel with increased IgG, suggesting, it wouldn't be proved by this, suggesting that somehow IgE is a marker of some sort of protection. And even though there was a lot of exposure, the kids were protected. So this is Dr. Noon, who 100 years ago reported in the Lancet the prophylactic inoculation against hay fever. And he did that at St. Mary's Hospital. And does anybody else, except for Daniel, who comes every year, does anybody else know what else happened at St. Mary's Hospital that's very important? Here's a hint. So, exactly, that's Alexander Fleming, who later isolated penicillin at St. Mary's. So what is antigen-specific immunotherapy? What did Dr. Noon do? Even though he didn't understand the immunology really at all, he thought he was dealing with a toxin. He thought the allergens were toxins and that he was generating an antitoxin. He had the vaccine model in mind, right? So you give incremental divided doses of the offending antigen, the toxin in his terminology. It results in a protective immune response, and it's a little bit like vaccination. And the history of understanding how it's working is the history of our understanding of immunity. And whatever is popular at the time is focused on. So at first it was a blocking factor in the serum. You could take serum from somebody who was immunized against hay fever and transfer it. They did things like that in those days, and it would carry the protective effect to another person. So that was a serum factor. The first randomized controlled trial didn't get done until 1954, and that confirmed it was working. It was known that in the 70s that it was associated with an IgG response to the allergen, like I showed you in Tom Platts-Mill's study with cat allergy. In the 1990s, there was a T1, Th1, Th2 focus, and so it was shown that this somehow was associated with reduced numbers of Th2 cells in some patients and more Th1. And then, of course, Mark, it's the holy grail, right? Regulatory T cells. So regulatory T cells are very popular now, and so it's clear that with antigen-specific immunotherapy, you do increase the number of Tregs, and you increase the number of other regulatory cells that can be produced between them, IL-10 and TGF-beta. And this is important. This is very hopeful. Of course, this is written by somebody who's a proponent of this. I mean, this is antigen-specific treatment, and it is curative. I mean, this isn't like using a leukotriene antagonist or an antihistamine or a beta agonist to treat the symptoms. This is treating the underlying problem. Now, it may require providing maintenance doses of the antigen. In some of the trials that were done early on, protection could last several years, but often patients get additional treatment to maintain that good response. But it actually can virtually eliminate the problem, if not cure the problem. So here's the black box of allergen-specific immunotherapy, and you can read all the good things that this does. These are the clinical effects. These are the effects on the various effector mechanisms. It decreases allergen-specific IgE. It decreases seasonal increases in IgE. It decreases, because IgE is decreased, this IgE-dependent facilitated antigen presentation. It increases blocking antibodies. So if you're doing an in vitro test where you activate mast cells with IgE and antigen, if you give enough IgG to capture the antigen before it gets to the IgE and the mast cell surface, you can block that reaction. So that's the term blocking antibodies, and those could be IgG1 or IgG4. It increases IL-10. And so what is in the black box? We like to now put in the black box the regulatory T cell, because it does a lot of these things. But there so far is no treatment that either gives regulatory T cells to people as the only treatment and proves that that by itself can reverse the allergic problem. But there's a lot of circumstantial evidence that they're important in the treatment with a specific antigen that results in allergen-specific immunosuppression or elimination of the allergic response. So if you like these bubble diagrams, you can think of health as being dominated by the regulation of both the Th1 and the Th2 type response. Autoimmunity as having an expansion of the Th1 bubble, and allergy an expansion of the Th2 bubble. And what antigen-specific immunotherapy does is try to redress this balance. And there's really evidence for two kinds of mechanisms. One is regulation. There's certainly induction of antigen-specific T regulatory cells in allergen immunotherapy. And there's also immune deviation, that is, there's a predominance of Th1 versus Th2 activity. And how much each contributes to this is a matter of debate and experimentation at this point. And so if this is the bad side, the red, and this is the good side, allergen-specific immunotherapy shifts things to the good side. So this is the problem, allergen-specific IgE activation of mast cells and basophils, and this amplification mechanism, among others, facilitated antigen presentation. And on the cell-mediated arm, potentially pathogenic effector helper T cells. These can be Th2, Th17. These innate cells also contribute. And then once you've had successful allergen-specific immunotherapy, you've got allergen-specific IgG and IgG4. Some of these have so-called blocking activity, and you have both natural regulatory and induced, I use the word suppressor cell, induced regulatory cell, and this can keep the allergic manifestations limited or eliminate them entirely. There's a lot of investigation in how to make this better. It turns out that most allergen preparations that had been used by allergists were very crude preparations where the specific allergen of interest may not even be detectable, and other things were, lipopolysaccharide and so forth. So there's a variety of approaches taken right now to make this better, and I'm going to illustrate with two of them very quickly. So in this case, they decided to generate recombinant allergens. So they knew exactly what was in the preparation, and they could exclude things they didn't want, such as LPS. And this actually worked quite well. This is a way of analyzing symptoms and medication use. This is the kind of aggregate score. So compared to placebo, these folks did better. And if you look at their grass pollen-specific IgE, it goes down over time compared to the placebo-treated group. This is a weak scale. IgG1 rapidly went up, much faster than IgE came down. And the same thing for IgG4, rapidly went up faster than IgE went down. So there was benefit using recombinant allergens, and I would say the field is moving toward recombinant allergens. Now, the allergens, of course, by definition, they're allergens. They can induce an IgE response. So what's the danger of immunotherapy with those allergens? Yeah, in a worst case, anaphylaxis. And particularly in the United States, a lot of the allergen-specific immunotherapy is subcutaneous. So you've injected the whole dose, and if in a worst case, again, it would be anaphylaxis. Not for hay fever, typically. It's more often the case in something like food allergy that you would get an anaphylactic outcome. So with the subcutaneous injections, this is done in a physician's office, and they're ready to treat the worst reactions if they occur and so forth. So in Europe particularly, they're going to sublingual immunotherapy, where you just put a tablet under your tongue, and you can always spit it out if the reaction seems to be too great and so forth. And it seems to be working reasonably well and may eventually be introduced here. So the allergen, because it can induce an IgE response, that's certain epitopes of the allergen, right? But the protein may be much bigger than that. So another approach that Rudy Valenta and colleagues are using is get rid of the epitopes that induce the IgE response and just use the other epitopes that may induce an IgG response. And these are called hypoallergens. So they aren't as good at inducing IgE, and they're good at inducing IgG. And this seems to be working well also, at least in trials. So here's the placebo treatment. They're measuring here the amount of IgG. Remember, that's kind of a marker of its working. And here they're using individual fragments, and here they're using trimers. And these were engineered to try to eliminate the epitopes that most frequently cause an IgE response. And this seems to be working as well. So this is also being explored as a better treatment, because you would be much less likely to induce an IgE-dependent adverse event here than you would with the entire allergen. So let's go back to this. What are we going to do about this? So there's been some discussion about taking people at risk of developing allergic diseases and actually vaccinating them, or getting them not to develop the allergic disease in the first place. But, I'm not sure that's going to get much traction. I mean, most allergic diseases are not that, I can say this, I don't happen to have them, but they're usually not life-threatening. So to the idea that you would be vaccinating somebody with an allergen where you might induce an adverse reaction, people just don't want to think about that. So for the most part, except for environmental modification, like camping out in a German farming shed, maybe that would work, or certain probiotics and so forth, you can modify the environment to some extent. But we're going to be dealt with allergic individuals who come to you with allergic diseases. So how do you go about treating them? So remember, it's a complex situation, but I've emphasized, and others have as well, IgE clearly seems to play some important role. So why don't we go after the IgE? And also, mast cells seem to play an important role, so let's go after them and so forth. And I'll briefly discuss that. So let's say you wanted to target the IgE, high-affinity IgE receptor mast cell effector pathway. So B cells making it, it's binding to the high-affinity IgE receptor. They get aggregated by antigen. This is a bad figure because there should be one there that somehow dropped out, retired. And this activated mast cell is producing all these mediators. Of course, you can treat for the effects of the mediators. That would be one approach. But let's think about this axis, the IgE mast cell axis. So, and this is I didn't mention this because it's not active, but I was one of the first consultants to Genentech on omalizumab, and I told them that my guess was that it would help some people but not others, and that's a pretty safe guess. Turned out to be right. So it's now approved for moderate to severe asthmatics. And why moderate to severe asthmatics? Well, it's very expensive. This is a humanized recombinant antibody, and it's injected subcutaneously. And what has it told us? It's told us that at least in the responsive patients, not all of them, but the ones who have benefit, the IgE axis is important. It doesn't say exactly how it's important, whether it's interfering mostly with this or with some of the amplification mechanisms or exactly what. But certainly it's a proof of concept that targeting this pathway, at least by reducing IgE, can work. And it's directed at a part of the IgE that's necessary for binding to the mast cell. And of course, what would be theoretically the worst case scenario about an anti-IgE? So why does bivalent antigen or multivalent antigen trigger mast cell activation? Because it aggregates the IgE and approximates the receptors. So you can also activate mast cells in vitro with anti-IgE if it's working on an IgE that's sticking off the cell. But this IgE is binding to a part of the IgE that is required for binding to the receptor. But one of the biggest problems was, is this going to cause the problem we're trying to eliminate? And it basically, for the most part, does it. There have been a few instances where it seems to have induced something like an immediate response, but that's very unusual. But the real problem is it's very expensive and it's inconvenient, it's subcutaneous. So of course, what are people looking for? Small molecules. And they're looking for molecule inhibitors of IgE production, IgE binding to the Fc epsilon R1. And so it turns out that the IgE is shown here as a Y, but it's actually sort of like a J. The Fc portion is curved. And crystallographic analysis has shown that when the Fc portion of the IgE molecule binds to the receptor, there's conformational changes that occur in both that make the binding very tight. There's a very slow off rate. The Kd of this interaction is about 10 to the 10th. And so these small molecules that are being screened they're looking for molecules that will either prevent the IgE from binding or will stabilize an inactive conformation. And a person doing some of this work is Brian Sutton in the UK. And he says he's got some very exciting results, but he wouldn't tell me what they were. We'll see. This is Mary Hewitt Lovelace. She was Stanford University, AB 1921, MD 1925. And when she entered the field of allergy, how allergists were treating people with bee or wasp venom anaphylaxis was to take ground up bodies of the offending insects and very slowly inject increasing amounts of those insect bodies into the patients. And why did they think this was working? So the patients came to them because they had had anaphylaxis when stung by a bee, right? And so how would you tell that your treatment is working? They get stung again and they don't get anaphylaxis. So you're looking for a clinical outcome. And what their experience was, roughly half the people so treated, if they were stung again, would not get anaphylaxis. So was it working? Yes, no? Not necessarily. That's the right answer. Why is it not necessarily that it was working? Somebody said you need a control, right? So what's the control? Placebo, right? And that, she didn't do that, actually. Larry Lichtenstein did that many years later. He did a randomized controlled trial using the therapy she developed. So what was the therapy she developed and published in 1956? And by that time, she was at Cornell. She thought, well, only half the patients are getting some sort of a response, so we should be able to do better than that. And you know, the insect doesn't dive into your skin and the whole body goes in. You know, they inject venom and then in some cases they fly away. So let's isolate the venom sac. So this is choice of antigen. So she made a better choice of antigen. And she started injecting that in very small amounts, and she protected over 90%. Now, there was a higher risk of what? Anaphylaxis. There's a higher risk of producing it because you're using exactly the right allergen, and you're giving it in exactly the same way. You're injecting it into the skin and so forth. But nonetheless, you know, 90% protection. So Larry Lichtenstein, years later, said, well, we've got to do a randomized placebo-controlled trial, which they stopped. So they had three groups. They had people who were getting placebo, people who were getting the insect bodies, and people who were getting the venom. And it was so what they found is whether you got the placebo or the insect body, how many people get anaphylaxis if they're stung? 50%. So that was the baseline, and that is very encouraging. It says even for something as dramatic as anaphylaxis to a bee or a wasp sting, there are regulatory mechanisms that can be elicited in half the people that are going to control that, and only happen once. But the purified venom worked very well. It's still the standard of care. So you have to think about the allergen, you have to think about the route of administration, you have to think about what's the baseline, what if you did nothing, and so forth, in order to get this right. But she got it right very early. So there are now two main approaches you can take with people with allergic diseases. And the desensitization I'm going to talk about here is if you've got a patient with an IgE-dependent, potentially anaphylactic reaction to penicillin, and you need to give them penicillin. So this is to link Alexander Fleming with Dr. Noon. So how are you going to do that? Well, you have to quickly get them desensitized to penicillin. This one over here, this is what we're trying to achieve, long-term cure of a problem by long-term tolerance. And what's the difference here? Well, here, this rapid and careful escalation, this is done in a hospital, by the way, you know, from low to high dose of antigen. So every 15 minutes, you basically increase the amount you give, and you keep going log-fold higher over a very short period of time. That's too short to affect T cells or antibody production. That's somehow working through an effect on the effector cell and reducing, we know it reduces mast cell and basophil activation. We don't exactly know how. It might be through depletion of signaling molecules or something. So you start with a tiny amount and rapidly go up. So that's desensitization. But you have to keep doing this. You can't stop, because if you stop, the reaction comes back. So you have to maintain that. Now over here, this is where you have a longer run-in. So you're giving low doses and then high doses, and you're working over a long period of time. And regulatory cells clearly have a role. We don't know how important a role, but they're clearly involved in that they're induced, and you can measure increased levels of cytokines in experimental settings that would have immunosuppressive effects. So here you're deviating the immune response away from a Th2 response. It's antigen specific, it's Treg dependent, at least in animal models, and it decreases T effector function, decreases IgE, increases IgG, and this is a slow process. Now, even here, in hay fever, it may last a couple of years, and then you give some maintenance therapy to maintain the state of, let's call it, tolerance. In food allergy, it isn't yet clear whether this is going to be achievable, and it isn't yet clear in the ones who show benefit from doing this with peanut, using peanut as the allergen, whether you have to keep giving the allergen, meaning it's a form of sort of almost somewhere between tolerance and desensitization, or whether you've achieved true tolerance, because people have not yet done controlled trials where they either stop the maintenance doses of peanuts or maintain them. But those are the general approaches that are being taken. And thank you for your attention. Now, Daniel.
I have a question which I would like to know if there is any difference in the ability of the IgE bound to an allergen to its high affinity receptors compared to an IgE that is unbound. Because usually with IgG what we see is that you first bind the antigen and then you get a much higher affinity to its receptor.
Yeah.
Now here it seems to be the other way around, as if the mast cell is first capturing the non-allergen bound and waiting for the allergen.
Yeah. Well, one way to reduce the mast cell response if triggering has begun is to give monovalent hapten. Remember I said that in order to activate the aggregation of the receptor, the antigen had to be at least bivalent or multivalent. Now, if you start that process and come in with monovalent hapten, you reduce and eventually reverse aggregate formation so that the reaction is stopped. So it doesn't directly answer your question. I'm not sure if anyone has actually measured that. I mean, you could do it with a hapten. You could have because the IgE would remain monovalent. That, I guess, would be an easy experiment to do, but I'm not sure if anybody's, I don't know if it's known. But in the case of triggering event, that's a bivalent hapten, and that definitely causes rigidity of the IgE binding to the receptor in the membrane and brings those close together. So I think that's a situation where it would be difficult to measure, I think, KD under those circumstances.
Unless you come with a construct that's made
Yeah.
of an Fc affinity receptor that doesn't have, click the receptor that doesn't have the inside signal.
Yeah. But I mean, basically, I don't know the answer to your question or whether it's known. Yes?
With the increased use of biologic therapies, and obviously the induction of antibodies against those biologic
Yeah.
therapies, is there also now increased use of tolerance type of algorithms or clinical use of those to induce tolerance for patients who mount some type of initial response?
Well, the one that's been best studied, I'll go back to the example of food allergy. So if you have a highly peanut allergic kid and you start giving that person a small amount of peanut to begin the process of tolerance induction, there are a few studies now that show that if you cover that child with this antibody, omalizumab, to reduce IgE during that period, it seems to go with fewer adverse effects. So that would be an example where you know that the pathogenic antibody is IgE. That's what you're trying to reduce with the tolerization protocol, and that you're giving the antigen that could cause the reaction. And so giving the anti-IgE at that time makes it a safer protocol. I'm not sure whether omalizumab specifically to reduce IgE has been used in other settings. Generally, these, thankfully, the reactions to biologics generally are not anaphylaxis, although certainly it's been reported. It's even been reported with omalizumab.
It's been reported up to 20% of the patients using infliximab have some sort of clinical manifestations, and that's what I was referring to.
Yeah.
If there's any standard protocols that have been.
Not that I know of.
Those are it's in the realm of case reports, and those aren't IgEs though. These
Yeah.
are IgG,
Right.
anti-epitope antibodies for the most
Yeah.
part.
Others? Yes. I'm having a little trouble hearing because of background.
I'm curious about the fact that there's a range of clinical severity of symptomatology.
Uh-huh. Yeah.
And is it really just a matter of dosage, purity of antigen, or those kinds of things, or is there a possibility of some kind of a regulatory mechanism to control what's happening, like an complement cascade?
Yeah. Well, I'll answer it this way. I don't think we have all of these mechanisms so we can eat a peanut and die. Right? So even though parasitism is less in our population than it once was, this evolved for something other than heightening reactivity to house dust mites. So I think there's considerable individual variation. Why do some people exposed to cats develop a severe allergy to cats like my friend, and others certainly have an immune response, but it's an IgG dominant response and they can coexist with their cat perfectly happily. I think that reflects that we're dealing with a genetically outbred population and that there's some sort of a balance in the benefit of having this sort of a response when you need it, and maybe we need it less than we once did since we're doing better with regulating parasitic diseases, versus the negative consequences of not having it, or the consequences of having it but against a totally benign environmental substance. It turns out that I mentioned it in passing, but mast cells, a lot of their dry weight is proteases, and it's not really been that clear what these proteases do, although some of them were on my charts as having effects in asthma and so forth. And so you can look at mice that either lack mast cells or that lack specific mast cell proteases and ask what's wrong with them. Why would we need these cells? And it turns out that at least two of the proteases, carboxypeptidase A3 and chymase, mast cell protease 4, can degrade toxic peptides that are in animal venoms. So these would be rattlesnakes, Israeli mole viper, Gila monster, scorpions, honeybee. So if you're a mouse and you don't have mast cells, you're increasingly, your susceptibility to those venoms is markedly increased. If you have mast cells, it goes to wild type levels. Of course, you can give enough venom to kill anything if you give enough venom. But it's like a tenfold difference in some of the amounts of venom needed to kill the animal. And if you put in mast cells that lack the critical protease, they don't work. So one thought is that the innate role of the cell was to enhance host resistance to venom-related toxins, which as vertebrates we were exposed to for a very long period over evolutionary time. And that only after the adaptive immune response developed in vertebrates did the cells learn how to bind antibodies. And what would that be good for in an anti-venom response? That would make the release of proteases even faster and more widespread. So that would be a benefit. But if you're unlucky enough to be one of those individuals who is maybe missing some regulatory element that would keep that in check, then the tip of that iceberg is anaphylaxis in its most extreme form. So you get, the mast cell has proteases that reduce the toxicity of bee venom, which is good, but you can develop a fatal anaphylactic reactivity to bee venom, which of course is bad. And it may be a kind of balance of the cost and benefit of that response. So my alternative ending slide, which I put in just for fun, is this one. So these are the different types of reptiles for which mast cells provide benefit by degrading their venom. So I told you that I'll end. Shiv does this much better than I do, but I'll end with two short poems. The first about mast cells, the bad guys, and the second about mast cells, the good guys. So Paul Ehrlich first gave them their name. We now know they're not all the same. But since they contribute to wheezing, and since they contribute to sneezing and in asthma to wheezing, that we have them at all seems a shame. So that's the mast cell as a bad guy. The mast cell as a good guy is the mast cell has earned a bad name because for wheezing it's partly to blame. But they also keep us all healthy despite challenges stealthy by helping us win in the host defense game. And now I think it's time for lunch.
Lunch, that's beautiful segue into lunch.